everybody, and to some of you, good morning. My name is Aza. I'm an IR fellow at Muhimbili University. Welcome. We're very glad to see everybody that's been signed in today. So this is another IR Grand Round. We'll be having a presentation on anticoagulation in IR, which will be presented by Dr. Ivan Rukundo, who is also a second-year fellow in interventional radiology at Muhimbili University. And with us today, we have an IR faculty who is Dr. Paul Suhoki. He's an associate professor of vascular and interventional radiology in Durham, North Carolina, and has over 36 years of experience in the field of interventional radiology. He graduated from Georgetown University School of Medicine in 1985, and he's also affiliated with Duke University Hospital. So I would like to take this opportunity to first welcome Dr. Suhoki. And if you have a few words, you can go ahead and say them before we start the presentation with Ivan. Welcome, Dr. Suhoki.
I think you're muted, Dr. Paul.
You're muted.
Sorry. Thank you, Aza. I know Ivan put a lot of work into this presentation. It's a very difficult topic to cover with a lot of material. So I'm looking forward to it.
Thank you very much. Yeah. So before Ivan starts, I would like to remind everybody to please mute yourselves. Presentation. Please mute everybody else who's not involved in speaking. Please mute your mics. Thank you very much. Ivan, what?
Yeah, so thank you so much, Aza, and everyone. Thank you for this opportunity. And good morning and good afternoon, depending on where you're joining from. I'm so privileged to have this talk, to make this talk with everyone. My name is Ivan, like Aza introduced me. I'm an IR fellow at Muhimbili in Tanzania. And thank you so much, Paul, for your mentorship and for being there. Today we shall be talking about anticoagulation in IR, and our read will be based on the updates or current SIR 2019 SOPs for coagulation. So, as maybe if we can mute everyone.
Okay, go ahead. You're muted, Ivan.
Yeah, sorry for that. So, as I said, we shared two articles that were published in JVIR in 2019 on the current SIR guidelines on peri-procedural management of thrombotic and bleeding risk in patients undergoing percutaneous image-guided interventions. And for this purpose, for the purpose of the talk today, we shall be talking about the part 2 of these guidelines, which mainly talk about recommendations that are made in consensus with this guideline update. The other article was on part 1, which we are not going to be covering today, and it was mainly focused on classes of anticoagulation medication and clinical considerations common in patients requiring percutaneous image-guided interventions. So regarding image-guided interventions, available data on pre-procedural coagulation is actually only limited to a few retrospective series that were done. And there is actually minimal availability of high quality randomized data to qualify this. So to overcome this lack of specific data, the SIR made consensus guidelines based on a multidisciplinary approach. And I would say that they recommend that different institutions can use this and come up with a multidisciplinary consensus that is developed for management protocols that pretty much best fits them. So how do you approach or assess a patient before a procedure? You will consider their clinical status. And by clinical status here, we mean reviewing their thrombotic risks, reviewing their bleeding risks, and as well as if there is any risk that is brought about by the procedure that you're doing. Your assessment should involve identifying whether these patients are on anticoagulation. And with that, you have to determine whether you hold this anticoagulation, or if you hold it after the procedure, do you have to reinitiate it, and when do you have to reinitiate this? So you have to also be conversant with the patient's thromboembolic risk, like I've said. And examples of these would be reviewing your patients and knowing if they have a big risk to these thrombotic risks, like patients who recently had stroke, patients who have a risk of thromboembolic events, and patients who have underlying malignancy, patients who have a significant history of cardiovascular disease. And you should be having an idea of the fatality rates that are attached to these different conditions. For example, it is known that 17.5% of patients who have mechanical valve have a risk of having thrombosis. And there are different percentage of fatality rates for different conditions like venous thromboembolism and patients who had embolic stroke. Stroke risk is calculated using this score, the CHA-2DS2 vascular score, and this predicts like an annual risk of stroke, whereby if you have a score that is less than 4, then your thromboembolic risk is regarded low, and if it's between 5 to 6, your thromboembolic risk is regarded moderate. More than 7, your thromboembolic risk is regarded high. It is also important to note that stroke in the past 3 months is considered a high risk. So regarding venous thromboembolic risk, you have almost like three factors to consider. You have to consider the acuity of the stroke, and by this we mean that if you had a clot within the past 30 days, the reoccurrence is high. So you have a high risk of developing this again. And if it's more than 3 months, it's regarded that the reoccurrence might be less. So clot type and location is also another important thing to identify in your patients. Identifying whether these patients have a cancer or are obese, or these are patients who have been immobilized for long. As we know, these are all associated with increased risk of thromboembolism. You have to assess whether these patients have mechanical valves, and by here we're talking about mainly patients who have a significant history of heart disease, patients with a history of coronary heart disease. And for patients with mechanical valves, you would want to think whether you're going to withhold anticoagulation for them, because withholding them puts them at a high risk of thrombosis. And while for patients who have acute coronary syndrome, in addition to a cardiac stent, if this was within 1 year, then they have a high risk of thrombosis. So this table here is just an illustration of what we just talked about for assessing thromboembolic risk. And this is the criteria that they consider with the CHA-2DS2 vascular score. Being a female carries some risk, congestive heart failure history, diabetes history, hypertension history, and all of these are put together with scores. You have to score them, and then you have to say if your patient has a high risk or they have a low risk, as we mentioned in the previous slides. So when we switch gears, you have to also be thinking about whether this patient has a bleeding risk. We've been talking about thromboembolic risk. So you have to assess whether these patients have some inherent conditions like bleeding, diastasis, if they have DIC, if they have renal dysfunction, for example, with patients who are on chronic dialysis, they have renal failure, patients who are septic, and all of this carries a risk of bleeding. And this is, for these two, you have to, there are scores that are there, different scores that are there that can help you predict whether these patients have a high bleeding risk. And to mention this, for patients who have mechanical valves plus a has bleed score that is more than 3, this predicts that they have a high risk of bleeding. So other bleeding risk scores that are known are the bleed map score, and the bleed map score has like 4 factors that are shown here: the history of bleeding, recent history of bleeding, mechanical mitral valve, active cancer patients, patients who have low platelets, and this will also increase as we expect. The more the score increases, then the more the bleeding risk increases. So we have a table here that also summarizes the risk assessment for bleeding using the HAS-bleed score. And as the abbreviation says it, we have hypertension, abnormal renal function, like we saw in the previous slides, abnormal liver function, prior stroke, history of major bleeding, age, and others. And all of this is put together to have a score, and a score that is more than 3 predicts bleeding events. So there was this algorithm that was put in this consensus guideline that shows how you have to approach a patient before you do a procedure. So this is a patient who is scheduled for an IR procedure and they are on anticoagulation. So the first question to ask yourself will be, can this patient be done on anticoagulation? So for some patients, you have to consider the patients are on anticoagulation, the procedure you're going to do, and if the planned procedure has a low bleeding risk and the patient has a low risk of bleeding, then you can go ahead and probably don't alter your anticoagulation medication. Go ahead and do the procedure. So some patients, this is not the condition. Sometimes the procedure you're going to do carries a high risk of bleeding due to the procedure, and the patient themselves maybe would be carrying a high risk of bleeding. So you have to again weigh and say, ask yourself if this is an emergent procedure or this is a procedure that you can take some time. And if this is an emergent procedure, you have to consider medications for reversal and go ahead and do the procedure. If it's not an emergency, you have to consider what thromboembolic risk do these patients have? Yes, they have a risk of bleeding, but do they also have a risk for thromboembolism? And how risky is it? And we saw how we can calculate or we can predict that. If the thromboembolic risk for them is low, then you can stop the anticoagulation and then go ahead and do the procedure. If the thromboembolic risk is high, you consider them for some bridging medication. You can put them on fractionated heparin or put them on some low molecular weight heparin if you want them to remain as outpatients. So then there are patients that you have, and these are on dual antiplatelet therapy, especially for patients who have like cardiac problems, chronic cardiac problems. And again, the approach is the same. You have to ask yourself whether these patients need this while you do the procedure, or they can stop it and you go ahead and do the procedure. So if your planned procedure has a very low risk of bleeding, you can continue the medication they are on and then do the procedure. If the procedure carries a high risk, then you also have to weigh. Like we said, if this patient has a mechanical valve, or they have a stent for patients who have coronary artery disease, and this was placed in less than a year, these are patients that you would go on and you wouldn't want to stop their their anticoagulation, you want to continue with them, at least continue with one of them, hold the second one for at least 5 days. And then again, this has to be in consultation with the cardiologists that are following these patients, with the vascular surgeons that take care of these patients. And like a team, you make a decision that you can go ahead and do the procedure. If the stent has been there for more than a year, and again, this becomes even trickier, and then you have to make a decision as a team. Every team that touches the patient, every team that is taking care of the patient should be involved in this discussion of whether you go ahead and do the procedure and how you are going to alter this medication. And then you have done your procedure, you have stopped someone's medication, or you have held them for a while, or they are not on, they are already on, you did never stop them. But in this case, let's say you stop them, you have to bear in mind that did this procedure cause a high risk of bleeding, or it's a low risk of bleeding. It's if it's a low risk of bleeding, then you have to assess whether you have to put what was their main indication for having anticoagulation. Are they patients who have atrial fibrillation? Are they patients who have a risk of thromboembolic events or history of thromboembolic events? Are they patients with who have a mechanical heart valve? And then depending on each of the conditions, you decide which one pushes you to restart the anticoagulation very quickly, or which one pushes you to bridge them a little bit before you can continue the anticoagulation. And then if it's a high risk, then you also have to assess if these patients have, how risky is their thromboembolic risk? Are they going to have thromboembolism like come back very quickly? And then you have to decide if you have to continue their medication quickly, you have to hold them, or you have to bridge them. So switching gears, we were talking about patient risk of bleeding and patient risk of thromboembolic events. Now, procedures themselves that we do may be carrying some risk of bleeding. And we're going to see what kind of procedures are considered low risk or high risk. So the Society of Interventional Radiology, especially this current guideline in 2019, classifies them in two categories. Our procedures are classified in two categories. They are the low bleeding risk procedures and the high bleeding risk procedures. And for it to be a low bleeding risk procedures, you have to think about whether this procedure, whether you expect any hemorrhage in this procedure, or whether if you had a bleeding, would it be easy to diagnose, or would it be easy to control? If it's easy, then that could be a procedure, that's a procedure that you regard as low bleeding risk. If it's a high bleeding risk, these are procedures that you already expect that these patients might have some bleeding complications, and or maybe if they have bleeding, it may be difficult to treat or difficult to diagnose. Or sometimes it may be even carrying like you may be having some minor bleeds that are in places that may cause devastating consequences. So you have to consider all this again for your procedures. So SIR recommends that for patients with high bleeding risk, a multidisciplinary team should come together, and you should make a shared decision on regarding the management of these patients, especially peri-procedure, before the procedure, within the procedure, and after the procedure. And mainly we are talking about these patients because they are mainly handled by probably cardiology, internal medicine, oncology, hematology, and you have to come together to decide what you're going to do for these patients along the time they're having the procedure and after the procedure. So there is generally insufficient data to support whether there is need for pre-procedural lab testing generally. But again, with the SIR recommendations, there were some recommendations that were put ahead for this. And because of the bleeding risks that are carried with some procedures and some conditions of patients, if you have you're anticipating to do a low bleeding risk procedure, you have to think about whether they have inherent bleeding risks like hematologic risks, they are on warfarin like we saw, or unfractionated heparin. and then you can do, if these patients have these inherent bleeding risks and they are either on medication, then you have to do some pre-procedure lab testing, and we are going to see what is the most important to do. And for all high bleeding risk procedures, it's mandatory to at least do some blood workup for these patients before you do a procedure on them. And so these are the key lab parameters for reference, and mainly we shall see that we're going to be talking about INR and platelets, and for some conditions you may add one or two other procedures, two other lab testing to do. And for patients who have low bleeding risk procedures, you consider your INR to be in the range at least less or equal to 2. Some of them you may be acceptable to go above 2. So this is how it's put. And for platelets, you can go as low as 20,000, but not go below 20,000 for platelets when you're going to do a low bleeding risk procedure. So there are a long list of procedures that you are regarded low risk procedures. Procedures like catheter exchanges, uh, which mean like G-tubes, biliary nephrostomies, abscesses. All of these are regarded low-risk procedures. Diagnostic arteriographies and arterial interventions. And here for arterial interventions, I would note that these are patients where you expect to use a sheath that is not more than 6 French. Then we have diagnostic venography and select venous interventions. We have non-tunneled venous access and their removal. Then peripheral nerve blocks and MSK injections. The list is long, and we shared these articles. You may want to pass through them and know which procedure lies in which category as it regards to bleeding risk for these procedures. So high bleeding risk procedures, we generally want to put our threshold for lab results low, and so our INR should generally be between 1.5 to 1.8, or generally lower than that. Make sure that you don't increase their bleeding risk, and then platelets should be at least more than 50,000. So high bleeding risk procedures involve ablations for solid organs and bone, arterial interventions where you expect to use like large sheaths at least above 7, biliary interventions, catheter-directed thrombolysis like in DVT, portal vein thrombosis, pulmonary embolism, portal vein interventions, and many procedures that we can see from the guidelines. So there's another category of patients who have chronic liver disease, and these are patients that can be difficult to manage their bleeding indices. These are patients that may have really deranged bleeding indices that are even hard to control. So in these patients, the recommendations are that you judiciously give plasma and platelets because of the potential for increased portal pressure and transfusion-related adverse events. So you should consider correcting their INR and platelet counts more aggressively than in the general population to minimize their unnecessary transfusions. So here you also have to take into account their fibrinogen levels if necessary. And if they're low, you may want to give them cryoprecipitate. This is a small table that talks about the thresholds for case of patients who have chronic liver disease. So just a summary from these recommendations, I would say that decision-making in peri-procedural management of thrombotic bleeding or bleeding risk patients should be take into account the medication they are on, and take into account their clinical condition. So for you to determine to hold anticoagulation or antiplatelet agents before the procedure, during the procedure, or even after, you should consider that the patient thrombotic and bleeding risks, procedural risks of bleeding, and the pharmacology characteristics of these medications you want to hold. For you to then you should also be thinking about bridging anticoagulation before the procedure. And this is in case the patient has a risk of thrombosis of anticoagulation, and this is high. The bridging of a procedure after a procedure also depends on indication of anticoagulation. the thrombosis and bleeding risks, and whether the anticoagulant agent that the patient is receiving. So the last, I would say, to determine whether the patient can resume anticoagulation and platelet therapy after an invasive procedure should be based on the risk of the post-procedural bleeding, because you can determine this from the procedure you're going to do. And this is mainly determined from you as an interventionist. And the risk of thromboembolic events, which is usually maybe determined by the treating physician, a cardiologist, a hematologist, or anyone that is closely or has been long-term following these patients. So thank you so much. At this point, we will welcome questions and welcome. Thank you so much for listening.
Yes, thank you, Ivan, for the presentation. Dr. Paul, do you have anything to say?
Yes, Ivan, thank you so much, and congratulations on a great talk. We were all treated just now to a really nice overview of really difficult patients who are either hypercoagulable or who are at risk for bleeding during our procedures, and we have to manage their anticoagulation. I have the pleasure of the last 12 months with working with Ivan and Aza and Eric by Zoom mostly, and I'm having discussions back and forth every couple of weeks. And it's been really awesome to see their progress over the last 12 months at their hospital. Anticoagulation is a very, very difficult topic. And, you know, there are specialists who do this full time. So if you're encountering patients who fall into these categories, you're doing high risk procedures on them, and we're wondering what to do about their anticoagulation or how soon to restart their anticoagulation after your procedure. Don't be afraid to approach these specialists who deal with this every day, and they will counsel you and give you really good recommendations on how to prepare that patient for the procedure, and afterwards how to restart them on their anticoagulation. I can think of a couple examples we've had in really just the last couple of weeks at our hospital. We had one patient, 28 years old, who had a very interesting presentation. He came to the hospital with right shoulder pain, and he got x-rays of his right shoulder, and they were completely normal. And in a continued workup of his shoulder pain, he was found to have two large liver cysts, one of which ruptured, and he was found through serologic studies to have echinococcal cysts. So we had to treat this patient. He had already been on albendazole for 2 months, and our goal was to drain these two cysts and to sclerose them with alcohol. The complicating thing was that in those 2 months, he had a large pulmonary embolus and was on warfarin. He also had a history of heparin-induced thrombocytopenia. So we couldn't simply take him off his warfarin and bridge him with heparin in the hospital. And the recommendations from the anticoagulation doctor was to take him off his warfarin and start him on bivalirudin. And he was a very intelligent man and was able to do this at home, checking his INR every day for 5 days and starting himself on the bivalirudin, and then coming to our hospital when his INR was lower than 2, so we can treat his echinococcal cysts.
Yeah.
Another example is a patient we had a couple of weeks ago who had pancreatic cancer. It had encroached on his main portal vein. It had occluded portal venous inflow to the liver, and he was starting to get sequelae from that. We wanted to stent open his portal vein. As you know, patients with cancer are hypercoagulable. During our intervention, through accessing his liver, crossing the occlusion, balloon dilating, put a stent in there, he had thrombosed his whole intrahepatic portal venous system. So we had to work very quickly, give him a lot of heparin, and also give TPA into liver to restore flow to the liver so that we could have a successful result. And the third example I'll give you is also a couple of weeks ago, where a patient at an outside hospital had multiple attempts to do a TIPS procedure the patient was transferred to our hospital, we were successful at doing a TIPS. And because the patient had a history of pulmonary embolus and DVT, we had to restart him on his anticoagulation after our TIPS placement. And we restarted him 48 hours later. And he went home and had a massive bleed into his liver from an arterial bleed from the multiple interventions in his liver between the two hospitals trying to perform a TIPS. So he had to come back to the hospital and we had to embolize his hepatic artery because of his hemorrhagic complication. So there are three really nice examples. And as I told Aza, Eric, and Ivan, over the last 12 months, when you're doing interventional radiology, you really have to think 5 steps ahead every time. You know, what if this happens? What if this happens? What am I going to do? So in that last case I mentioned, we really had to keep in mind the fact that we are restarting this patient on heparin. He had multiple needle passes and interventions in his liver recently, and what if he bleeds into his liver? So we had to be prepared for that complication. The last thing I'll say is on that second journal article that you all have about anticoagulation, there are tables in there. I believe it's table 6. Table 6 is a really extensive review of all of the anticoagulation medications, everything you need to know about how to take them off the medications, how to bridge them, which anticoagulation to start in your practice for a given patient. It's an extremely helpful table. There's also a table there on blood products, platelets, packed red cells, how to approach that treatment for the patient. At our hospital, we have those tables taped to the wall in front of the resident's computer. So when they get a call on the phone, they are prepared to manage those patients. It's too much information to keep in your mind, so it's important to have them readily available, either on your smartphone or just having a physical list in front of you on the wall to look at. So thanks again, Ivan, and would like to invite any other questions that anyone has.
Thank you so much, Paul. Thank you so much. I would encourage, if you didn't get a chance to look through these articles, please find them. They are available and they are accessible. You can find them, and you might find much more information than what was presented for your use.
Thank you so much. So I don't see any questions in the chat box. Probably the presentation was that good. People don't have questions. So I don't know if we should end it up here for today.
Yeah.
Does anyone have any questions?
Yeah.
I guess not. Okay, so thank you very much again, Paul, for joining us. And thanks, Ivan, for the presentation. And thanks to everyone who was able to join in. Till next time. See you guys next week again, Thursday. We'll be having another presentation, IR Grand Round. Thank you.